A dog lover in Wisconsin woke up vomiting with pain running through his legs. The next morning, he could barely walk or speak clearly. At the hospital, bruise-like patches began appearing across his body, and within days, surgeons would have to remove both legs and part of both arms. He remembered no bite or scratch. Doctors suspected contact with dog saliva. Welcome to Diagnosis Glitch.
This story is based on documented events. All names are real. On June 26, 2018, Greg Manteufel looked like a man with a vicious stomach bug. He was 48 years old, living in West Bend, Wisconsin. He painted houses for a living, rode a motorcycle, and had spent his life around dogs. His wife, Dawn, worked nights. When she came home from her shift, Greg told her he had been vomiting and that his legs hurt. There was no dramatic wound to explain it. Greg and his family remembered no animal attack, bite, or scratch that would make a doctor immediately think about bacteria from a dog's mouth. Greg was simply sick. By early the next morning, that explanation was collapsing. His son heard him moving around the house. Greg was speaking in a way that did not make sense. He could barely walk. He also had diarrhea. His family got him to a hospital near their home, and during the short trip, Dawn noticed something that had not been there minutes earlier. Dark, bruise-like patches were appearing across Greg's body. They were not ordinary bruises. They were an external warning that something had gone catastrophically wrong inside his blood vessels. His care continued at Froedtert Hospital in Milwaukee. Blood tests eventually identified a bacterium with a name that sounds almost harmless when spoken slowly. Capnocytophaga canimorsus. It's commonly found in the mouths of dogs and cats. Most people live around these bacteria without ever knowing they exist. Most bites do not cause this particular infection. Most contact with pet saliva causes nothing at all. Greg's case was the exception that breaks the reassurance. His infection had entered his bloodstream and triggered sepsis. His immune system was no longer fighting a local invader. The response had become body-wide. Blood pressure fell, organs were threatened. Then his clotting system began turning against him. The condition is called disseminated intravascular coagulation, or DIC. Normally, clotting is local and deliberate. A vessel's damaged, a clot forms at that spot, and bleeding stops. In DIC, the system fires across the circulation. Tiny clots form inside small blood vessels throughout the body. They consume platelets and clotting proteins as they spread, which creates a contradiction. The patient can be clotting and bleeding at the same time. For Greg, the clots strangled circulation to the parts of his body farthest from his heart. That is what the bruise-like patches were announcing. Blood could no longer reach his hands and feet normally. Without oxygen, tissue began to die. Antibiotics could attack the bacteria, but they could not restore tissue that had already lost its blood supply. The infection was clearing. The damage kept advancing. Surgeons first removed Greg's legs below the knees. Later, they removed parts of both forearms. Reports from his hospitalization describe at least 10 operations before he was discharged. The familiar version of this story says that a dog licked a man and doctors took his hands and feet. The documented version is more careful and, in some ways, more frightening. Greg had been around several dogs, including his own pit bull. His family said he had no remembered bite or scratch. His doctors believed dog saliva was likely the source, possibly transferred to an opening in the skin or to his mouth or eye, but no one witnessed the exact moment of transmission and no test could identify which dog was involved. The lick was a clinical inference, not a recorded event. That distinction matters. It prevents a rare infection from becoming a false warning that touching any dog is dangerous. It also reveals the real diagnostic problem. There may be no memorable exposure for the patient to report. A doctor cannot connect a bloodstream infection to a bite that never happened. The organism itself makes that uncertainty worse. Capnocytophaga species are described by the Centers for Disease Control and Prevention as fastidious, slow-growing, gram-negative bacteria. Fastidious means they're demanding. They may need particular conditions before they grow well enough in a laboratory to be noticed. Automated blood culture systems are designed to detect the behavior of bacteria growing in a bottle. A fast, abundant organism announces itself. A slow, difficult organism can remain quiet. Even after growth appears, biochemical identification can confuse Capnocytophaga with similar species. In one California study cited by the CDC, state public health laboratories correctly identified only about 1/3 of submitted Capnocytophaga samples. That study followed 56 human isolates submitted to California's reference laboratory across 32 years. Most of the patients did not arrive with a great, neat label attached to their blood sample. More than half of the isolates were sent to the reference laboratory as an unidentified gram-negative rod or simply as identification unknown. Others arrived under the wrong names, including organisms from entirely different groups. The problem was not that the bacteria was invisible under a microscope, they were unfamiliar and slow. Capnocytophaga grows better in a carbon dioxide-enriched environment and can require extended incubation. Its cells may appear as long, tapered rods, but appearance alone does not separate one species reliably from another. Commercial identification systems are optimized around organisms laboratories encounter more often. A rare bacteria may not fit their databases or biochemical panels cleanly. In 2 of the California cases, the submitted cultures were no longer viable by the time the reference laboratory tried to grow them again. Traditional identification had reached a dead end. PCR and sequencing of a portion of the bacterial ribosomal gene finally supplied the name. Without that molecular route, the researchers wrote those cases would have been missed. The study also shows why Greg's symptoms were easy to misread at the beginning. Fever was common, but so were abdominal pain, diarrhea, vomiting, headache, confusion, and muscle aches. Those findings describe sepsis, but they do not point uniquely toward an animal-associated organism. Animal exposure helped only when someone knew to ask. Among the 27 California patients with available exposure histories, 21 had a recent bite or a close contact with dogs or cats. That left patients for whom no useful animal link was recorded. Greg belonged to the hardest version of that group. He loved dogs and had been around several, but there was no memorable injury making the entrance. That does not mean Greg's hospital failed to run the right test. His physicians did identify the infection and treated it. The deeper glitch is that the diagnostic system is built around patterns, and Greg violated 2 of them at once. The first expected pattern is an obvious animal injury. CDC guidance emphasizes dog and cat bites because those are visible reported events. The patient remembers the bite. The clinician sees the wound. Saliva contact without a known opening is much harder to recognize. The second expected pattern is a vulnerable host. People with weakened immune systems, no spleen, or heavy alcohol use face a much greater risk of severe Capnocytophaga disease. According to the CDC, those medical histories account for about 60% of infections. Greg was reported as otherwise healthy. His treating physician, Sylvia Munez-Price, said it remained unclear why this particular 48-year-old developed such devastating complications. The risk categories explained many patients, they did not explain him. The same California series carried a brutal warning about what happened after DIC appeared. Outcome records were available for 30 patients, 10 died. 7 developed DIC or septic shock during hospitalization. In that historical series, every patient with Capnocytophaga-associated DIC died. Those numbers came from a small selected group of difficult cases sent to a reference laboratory. They're not a prediction for every infected person. They do, however, show the cliff Greg had reached. He did not merely survive a bacterium associated with high mortality and severe disease, he survived the complication that had marked the worst outcomes in that series. Survival required 2 battles at once. Clinicians had to cover a severe bloodstream infection with antibiotics before every laboratory detail was settled. At the same time, intensive care teams had to support blood pressure and organ function while surgeons judged which tissue had lost circulation permanently. The decisions can sound contradictory from outside the hospital. If the infection was clearing, why amputate? Because infection control and tissue viability are different clocks. Antibiotics can reduce or eliminate living bacteria in the blood. They cannot bring oxygen back to tissue after microvascular clots have destroyed its circulation long enough for gangrene to begin. Dead tissue can itself become a source of further infection and systemic stress. Amputation was not evidence that the antibiotics had failed, it was evidence that they had arrived in a body where the clotting catastrophe was already ahead. Medicine depends on categories because no clinician can test every patient for every rare organism. The categories make care possible, but when a patient falls outside them, the same tool that guides attention can also hide the answer. Greg did not look like the person in the warning, then the disease moved faster than the warning could be rewritten. CDC guidance says symptoms from animal-associated Capnocytophaga commonly begin 3 to 5 days after exposure. Early signs can resemble dozens of ordinary illnesses: fever, vomiting, diarrhea, muscle pain, headache, and confusion. In severe cases, the disease can progress rapidly into sepsis, shock, DIC, organ failure, and death. The first stage looks common. The second can become irreversible within hours. That is the diagnostic trap. If every person with vomiting and aching legs were tested for rare dog-associated bacteria, emergency medicine would drown in unnecessary testing. But if the clinician waits for a clear animal wound or a classic risk factor, a patient like Greg may already be losing circulation by the time the pattern becomes unmistakable. There is no perfect rule that resolves that tension. There's only better information. The CDC tells clinicians that its bacterial special pathogens branch is available around the clock for urgent Capnocytophaga consultation. It recommends molecular methods such as PCR, 16S ribosomal RNA amplification, and MALDI-TOF mass spectrometry when routine identification is unreliable. MALDI-TOF sounds like a piece of science fiction. It's a method that creates a molecular fingerprint from proteins in a bacterial colony and compares that pattern with a reference database. PCR and gene sequencing look at genetic material instead. These tools approach the same problem from different directions. When growth and biochemical behavior produce an ambiguous answer, identify the organism by what it is made of. Their usefulness still depends on suspicion. A molecular instrument is not a net cast automatically over every sample. Someone who has to decide that the ordinary result is incomplete, send the isolate onward, or ask a reference laboratory for help. The rare pathogen can therefore be defeated technically and missed operationally at the same time. Those tools can name the bacterium. They cannot give the limbs back. By September 2018, after weeks in the hospital and at least 10 surgeries, Greg was discharged. The next phase of his life would involve healing, rehabilitation, and prosthetics. At a news conference, his doctors praised his determination to walk again. Greg's response to the suspected source of his infection surprised almost everyone. He did not turn against dogs. Quote, "I can't just stop liking dogs because this happened. I'll always love dogs." That sentence prevents the story from becoming the wrong kind of warning. Greg did not want his survival turned into a campaign against pets. His doctor made the same point. She owned a dog herself and said most people would never experience an infection like this. The useful lesson is narrower. Dog and cat saliva contain bacteria. Intact skin is an excellent barrier. A bite, scratch, open wound, or sore creates a route around that barrier. People with weakened immunity, no spleen, or heavy alcohol use should be especially careful. A bite should be washed immediately with soap and water and discussed with a healthcare professional. The absence of pain is not proof that the barrier held. A small break in the skin may be forgotten or hidden beneath saliva, hair, or an existing sore. The first symptoms may appear days later and far from the entry point. That is why exposure history should include close animal contact, not only dramatic bites, when a patient develops unexplained rapidly progressive sepsis. The warning also has to remain proportional. Millions of people are licked by pets without becoming ill. Preventative antibiotics for every affectionate contact would expose people to side effects and drive antimicrobial resistance without meaningful benefit. The safer rule is targeted: protect broken skin, clean bites promptly, disclose animal exposure when serious symptoms follow, and lower the threshold for medical advice when known risk factors are present. Good prevention is not maximum fear. It's enough precision to recognize the unusual event without treating ordinary life as an emergency. But Greg's case adds an uncomfortable footnote to every prevention poster. Sometimes the route is not remembered. Sometimes the patient does not fit the high-risk box. Sometimes the first visible sign is not at the place where the bacterium entered. It is a patch of darkening skin somewhere else created by a clotting system collapsing throughout the body. And sometimes, by the time a rare disease finally becomes obvious, the most important part of treatment is no longer killing the organism, it's surviving what the organism has already set in motion. That's why sepsis is not simply an infection with a frightening name. It's a race between recognition and cascading damage. Antibiotics can stop bacterial growth, yet shock, inflammation, clotting, and organ injury can continue to determine the outcome. Greg's bacteria were susceptible to treatment. The circulation they destroyed was not recoverable. The difference between those two facts is the reason he survived without 4 limbs. There's another reason his case matters. Capnocytophaga infections are not nationally notifiable in the United States. Hospitals are not required to feed every diagnosis into one complete national count. The CDC therefore says there is no national incidence estimate. We know the disease is rare. We do not know its exact national rate. That gap shapes awareness. A condition without a clean count is difficult to teach, difficult to compare, and easy to remember only after a catastrophic case reaches the news. Public attention then swings too far in the opposite direction. A rare infection becomes the dog lick disease, as if the affectionate act itself routinely leads to amputation. Both extremes are failures. Ignoring the organism leaves clinicians and vulnerable patients without a usable warning. Sensationalizing it leaves millions of healthy pet owners frightened by an event that they're extraordinarily unlikely to experience. The accurate middle is less dramatic but more useful. Capnocytophaga lives in many animal mouths. Severe human infection is unusual. Saliva crossing a damaged barrier creates risk. Certain health conditions increase that risk sharply. The bacterium can be hard to identify, and when it does trigger septic shock and DIC, the damage can move with terrifying speed. Greg's story did not begin with a monstrous dog. It began with an ordinary relationship between a man and the animals he had always loved. The monster was a bacterium that normally lives without consequence, entering through a route no one could later prove in a patient who did not look vulnerable and turning his own clotting system into the mechanism of injury. He survived because his family recognized that the illness had become something more than the flu, because clinicians supported him through shock and organ-threatening disease, because antibiotics stopped the infection, and because surgeons removed tissue that could not be saved. Survival was not the same as restoration. That is the final contradiction. The medicine worked, the infection cleared, Greg went home, and none of those facts could reverse the few hours in which blood stopped reaching his hands and feet. The glitch was not one negligent person or one missing machine. It was the space between a rare organism and the familiar categories used to find it. Bite or no bite, vulnerable or healthy, infection controlled or damage contained. Greg fell between every pair. And yet, after all of it, he still refused to let the bacteria rewrite what dogs meant to him.
Greg's case is not proof that dogs are dangerous. It is proof that rare diseases become most dangerous when they arrive without the exposure or risk factors medicine expects. The bacterium was treatable, but the clotting cascade outran the diagnosis. In that gap, survival and recovery became two very different outcomes. I will see you in the next waiting room.